Madam, we are live now.
Yeah.
So good evening, doctors and all the participants. Today we are here with a very interesting and important topic that is stress and infertility. And our guest speaker is Dr. Sayamstuti Pattanaik, madam. It's my honor to introduce ma'am. Ma'am did her MBBS, MS OBGN. She is the consultant obstetrician and gynecologist and laparoscopic surgeon and infertility specialist in Shanti Memorial Hospital, Rourkela, Odisha. So with this short introduction, I request Madam to take over the session for this very interesting topic, and I would like to request all our participants, please post your queries in the dashboard of the Shield Connect chat box. So once the talk will be over, we will have a short discussion on this emerging topic with Madam. So thank you very much, Madam, once again for your valuable time on our platform Shield Connect, and over to you for further proceedings. Thank you very much.
Hello. Am I audible?
Yes, Madam.
Yeah. A very big thank you to Shield Connect for giving me this opportunity to speak and elaborate on stress and infertility, as we know that it is one of the very hot topics nowadays, and we have so many infertile couples coming only because of the reason of stress, which leads to all these things. Coming as I said, that it's a hot topic, and for us clinicians, and but it is very disheartening and very difficult for the people going through it. The patients are patients, and as the trend is towards infertility, the fertility potential of people going down because of various things, as we all know, with the changing era, with the modern lifestyle, with the society and their expectations, with women coming up at par with men. So everything, all the dynamics changing. I think this is a very, you can call it an epidemic. It's a new epidemic of young India. So India faces a high burden of infertility, with 22 to 33 million couples in the reproductive age suffering from lifetime infertility issue. 1 in every 4 couple in the reproductive age in India struggle with infertility, which is quite a big number, as we know our population dynamics, which this is quite a big number. More and more young Indians are finding it very hard to conceive. At least 10 to 15% of married couples are experiencing fertility issues. 40 to 50% of the cases are attributed to problems with women, while for the rest, it is the men, about 30 to 40%. So there is not quite much difference between men and women. They're equally affected by stress. Surprising fact is that male infertility in India is on a rise with every passing year. So we cannot underestimate the importance of male infertility and how stress is associated with it. So the factors that have impacted the infertility rate in India, as we can see, the different things. Stress is one of the very big parts of the pie chart, but the biggest one being the unhealthy eating habits, followed by older couple, then stress, then PCOD or PCOS, and then miscellaneous and other factors. Coming here to the graph, where we can see that, almost male and female are equally affected by infertility here, and combined is also another 10%, and unexplained, where we all do not like to go, which is another 10% of it. So being diagnosed with infertility, everyone reacts to the diagnosis of infertility differently. Diagnosed partners can experience several emotions like, shock, surprise, denial, a sense that the diagnosis is not really true. And this can also be described as feeling numb or not knowing what to do. So this anger and frustration, this can be expressed as, why is this happening to me? Or feeling angry at others. And the anxiety, fear, or panic, all thoughts are very confused. The isolation, also feeling different from others and feeling out of touch with your partner. The sense of loss. There are many aspects of grief covering, loss of pregnancy, loss of motherhood and fatherhood. These can continue through all stages of infertility. Can stress be a contributing factor for infertility? Yes, definitely. It is one of the biggest factors which contribute to infertility, either male or female. but people were unable to discover it, and I would more so say that it is the denial to accept this as a factor. But I think high time that we all accept it, discover it, and know why it affects it and to what extent. The social stigma, I think in our Indian society, it is quite more than the Western world. Social stigma can aggravate the stress levels. Link between stress and reproductive system has been well established, as we all know, since the onset of teens and reproductive age. We see so many things, the teenage stress, the married couple stress, or the menopausal stress. Any age group of the patient stress has definitely affected the hormones and the reproductive system and our hormonal axis in the body. Psychological stress experienced by female or male partners of infertile couples has been associated with lower conception rates. Data from animal models suggest psychological stress may be a major contributor to both male and female infertility. Stress can compromise every aspect of fertility, including libido, sperm quality, ovulatory capacity, and implantation. So at every stage, I think stress has a very big effect. Stress influences your reproductive function at all levels. As I said, it can interfere with the reproductive function at all levels of the reproductive axis. It can suppress the libido, reward and mating behavior at the level of the brain, particularly the ventral tegmental area. It interferes with the hypothalamic gonadotropin releasing hormone pulse generator, GnRH pulse generator. The LH and FSH release from the anterior pituitary. It suppresses oocyte maturation, ovulation at the level of the gonads, as well as increasing the likelihood of ovarian cysts and affecting both ovarian and testicular steroidogenesis. So if we go by the scientific terms, if there are people who are listening who are not from this background, can know what stress can do and how it can definitely affect each and every minute process in the axis. Stress is also detrimental to pregnancy outcomes post-conception, reducing the likelihood of successful blastocyst implantation. The hypothalamic pituitary adrenal axis, upon encountering a stressor, medial parvocellular corticotropin releasing hormone and arginine vasopressin neurons of the hypothalamus receive input from several brain regions, including the amygdala, brainstem, and the prefrontal cortex, and stimulate CRH release into the median eminence. So it also affects the HPA axis. And this is what the HPA axis is when stress is encountered. The CRH acts on the anterior pituitary through CRH receptor type 1, leading to release of ACTH into circulation, a peptide hormone derived from pro-opiomelanocortin or POMC. ACTH stimulates glucocorticoid release to regulate glucose and fat utilization and storage, memory, immune function, other stress coping strategies, as well as negatively feeding back on glucocorticoid and mineralocorticoid receptors in the hypothalamus and hippocampus to suppress further HPA axis activation. The hypothalamic pituitary gonadal HPG axis. The hypothalamic medial preoptic area kisspeptin or KIS1 neurons stimulate and gonadotropin inhibitory hormone GnRH hormones inhibit the gonadotropin releasing hormone pulsatile release into median eminence. GnRH release stimulates the release of gonadotropins, luteinizing hormone and FSH from the anterior pituitary. As we can see in the diagram, we can clearly see how it is happening from the medial preoptic area, the GnRH neurons acting on the anterior pituitary, FSH and LH release, then the surge leading to the ovulation and other things. As we all know, the tonic release and the growing follicle and the cycles. This in turn leads to the release of ovarian steroids, mainly estrogen and progesterone, that can carry out both negative and positive feedback actions depending on the stage of the ovarian cycle. In males, gonadal release of testosterone produces inhibitory actions on the GnRH or gonadotropin secretion. That is the negative feedback. Pituitary gonadotropins can also stimulate steroidogenesis. Intersection of the HPA and HPG axis. As we mentioned all the axis till now, the CRH can directly inhibit the gonadotropin releasing hormone pulse generator, leading to suppression of the pituitary gonadotropins LH and FSH, in turn resulting in diminished oocyte maturation and steroidogenesis. Glucocorticoids can act directly at the level of the pituitary to suppress gonadotropin release as well as to exert suppressive effects within the gonads. CRH release from the paraventricular nucleus of the hypothalamus activates locus coeruleus neurons or the LC neurons, releasing noradrenaline production. This stress-induced increase in sympathetic activity can then increase sympathetic innervation of the ovary, contributing to the development of ovarian cysts. So this is the basic thing, how the ovarian cysts develop. So this diagram also clearly depicts how stress leading to the locus coeruleus hypothalamus. Then we CRH of course is a negative feedback to the GnRH, but then we have FSH, LH and ACTH acting, FSH, LH acting on the ovary, ACTH acting on the adrenal cortex, and then all of it has a negative feedback, the glucocorticoids on the GnRH, and then again on the FSH, LH or the folliculogenesis. What does the research convey? Evaluation of the predictive factors of the psychological distress in women with unexplained infertility. As we can see in this one published, we find that anxiety and depressive symptoms are common among women with unexplained infertility, and strategies should be developed to better support and treat this high-risk population, because even if we know the factors, that is somehow very kind of relieving for the patient to know where is the problem and how to deal with it. But when it comes to the zone of the 10% of the patients which have unexplained infertility, for them, I think it is very, very difficult to cope with the anxiety and the depressive symptoms because they do not know what to do. Depression and emotional stress, highly prevalent among women with recurrent pregnancy loss. Is the prevalence of psychological stress and moderate or severe depression higher for women with recurrent pregnancy loss than pregnancy planners trying to conceive naturally? RPL has a significant emotional impact on couples, especially the woman. Previous studies have shown inconclusive results. Both psychological stress and major depression are significantly more common among women with RPL than in those trying to conceive naturally. This study should entail a heightened awareness of mental distress among care providers for women with RPL. So we need to be empathetic towards all of them, try to understand their mental background and what they're going through. When we're clinicians, it is also a part of our treatment to take care of their mental health. The investigation of holistic stress in infertile women and relation to demographic characteristics in women which were referred to the Yards Infertility Center. What did they find there? Infertility has a significant impact on the infertile woman's health. It is important psychological approach consider as an important part of the treatment inside other medical treatments. So definitely taking care of the psychological part is equally important than taking care of other elements. So Middle East Fertility Society Journal, we find another article here which says distribution of stress level among the infertility patients. What do we find in this? 22% of the infertile patients in the clinic experienced stress mainly associated with the duration of the infertility. So the longer the they have to wait or go through various procedures, the more they find the stress and the depression, anxiety and other things increasing. So in women, what do we see in women? I think women are much more highlighted than men, but I feel 40 and 40% is quite the same number in the pie chart as we say stress-induced problems. Coming to the anovulation, which is stress-induced, the percentage of it you can see it is 34% as compared to hyperandrogenism or prolactinemia or premature menopause or Asherman syndrome or others. So stress-induced anovulation or a functional hypothalamic amenorrhea is one of the biggest reasons for anovulation. How does stress affect the ovulation? When a person is under chronic stress, the HPA axis is activated, which leads to increased levels of cortisol and corticotropin releasing hormones. The increased cortisol and corticotropin hormone releasing hormone can suppress the normal levels of the reproductive hormones, which can potentially lead to abnormal ovulation, anovulation, and amenorrhea. So this is how it affects, and this is how there is also the mechanism of the weight gain and other things. How stress affects ovulation again? When there is a presence of adequate estrogen levels and there is stress-induced activation of the HPA axis, a significantly higher amount of LH is released. Studies have found that the increase in LH was most probably associated with the increase in adrenal progesterone, which should feedback negatively on the gonadotropins in the pituitary to reduce LH that accompanies the release of cortisol in response to the stress. So we see this cortisol is somehow produced in response to the stress. It has also been reported that progesterone can stimulate the LH secretion by acting directly on the pituitary. Because of the stimulation of the LH secretion, this may provoke a premature LH surge and thereby interfere with proper follicular maturation and ovulation. So there is a particular time of the LH surge, but when it happens a little early, it definitely hampers the maturation and the ovulation because of the stimulation of the LH secretion. Furthermore, elevated LH concentrations at different stages of the menstrual cycle may have conflicting effects on the maturing follicle and on the developing oocyte, and may result in early pregnancy loss due to the egg not implanting properly. Coming to another article, which is a review that is impact of stress on oocyte quality and reproductive outcome. The increased cortisol as well as oxidative stress levels affect the granulosa cell functions, possibly by inducing apoptosis. The granulosa cell apoptosis results in reduced estradiol, that's 17-beta biosynthesis in the ovary, which reduces growth and development of the follicular oocytes and induces oocyte apoptosis. Apoptosis deteriorates oocyte quality, leading to poor reproductive outcome in mammals, including humans. So this is the mechanism behind it. As we can see here, the pressure and demands, environmental changes, unknown factors leading to stress, and it affects the hypothalamus pituitary, the adrenal gland, the kidney, increased cortisol leading to decrease in the estradiol, reduced growth and development of oocytes, and oocyte apoptosis leading to deterioration of the oocyte quality and poor reproductive outcome. And also we can see the lifestyle changes and all these factors leading to alcohol consumption or smoking or other changes. They result in increase in the reactive oxygen species and cause an oxidative stress, which leads to again granulosa cell apoptosis, leading to decrease in the estradiol. So increase in cortisol and oxidative stress, both of them lead to decrease in estradiol and reduced development of the oocytes and again oocyte apoptosis. List of studies showing the effect of stress on ROS production and oocyte quality. So we have 3 or 4 human studies which we can see mentioned here. It induces poor IVF outcome. It generates reactive oxygen species and reduces oocyte quality. Alcohol and cigarette consumption reduces fertility in women. It has also been proved. And it leads to the maladapted lifestyle behaviors, that is alcohol and cigarette consumption. Stressful life events can cause stress hormone and impair the follicle maturation in the ovary. So coming to stress in endometrial receptivity, the human endometrium plays a vital role in providing the site for embryo implantation and maintaining the normal development and survival of the embryo. So recent studies have shown that stress is a common factor for the development of unexplained reproductive disorders. The non-receptive endometrium and disturbed early maternal fetal interaction might lead to infertility, including the repeated embryo implantation failure and recurrent some spontaneous abortion or late pregnancy complications, thereby affecting the quality of life as well as the psychological status of the affected individuals. Coming to the impact of stress on human endometrium. What does the stress do? Again, acting on brain, hypothalamus, pituitary. It acts on the HPG axis disruption, leading to decrease in GnRH and increase in FSH, leading to altered estradiol and progesterone, acting on the adrenal gland, leading to human endometrial dysfunction. So lower GnRH level, lower FSH and LH ratio, altered secretion of E2 and P2, inhibition of the epithelial and stromal cell proliferation, inhibition of the stromal cell differentiation, altered endometrial gene expression, impaired endometrial receptivity, affected embryo implantation and development. So this all leads to human endometrial dysfunction. Stress hormones increased, they lead to stress mediators in the human, they act on the stress mediators in the human endometrium, leading to human endometrial dysfunction. Coming to the male, how does stress affect infertility in male? Stress on the semen parameters. According to American Society of Reproductive Medicine, infertility affects men and women equally, and the semen quality is a key indicator of the male infertility. So that is the key and the common best test that we write for them, besides the DNA fragmentation index and other things. Men who feel stressed are more likely to have lower concentration of sperm in the ejaculate and than the people, and the sperm they have are more likely to mishappen or have impaired motility. This is another thing when we find a lot of percentage of impaired motility or immotility in our chart that we see, or in the result that we see after the semen analysis. We need to think about what occupation the person is and what kind of lifestyle the person is going through, and the various other stress factors. It may trigger the release of steroid hormones called glucocorticoids, which in turn could blunt levels of the testosterone and sperm production. Another possibility is oxidative stress, which has been shown, affecting the semen quality and fertility. Coming to another article where we can see what is the effect of the psychological stress on fertility hormones and seminal quality in male partners of the infertile couples. Persons having abnormal HADS had lower, serum total testosterone, higher serum FSH and LH than those persons having normal HADS. So the sperm count, motility, and morphologically normal spermatozoa were lower in persons having normal HADS. And what is the full form of HADS? It is a hospital anxiety and depression score. How do we measure it? We have all these factors involved in it. That is the luteinizing hormone, FSH, testosterone, GnRH, sperm count in millions, rapid sperm motility in percentage, normal sperm morphology in percentage, and we can see here HADS less than 8 and HADS more than 8. In the study population. So it definitely gives a picture about how stress is affecting the various parameters in the semen. Effect of emotional stress on sperm quality. Male patients with idiopathic infertility were selected for evaluation of psychological stress to evaluate a positive effect of stress therapy on the semen quality. Data showed that necrosis and apoptosis were higher. The number of healthy sperm was significantly reduced in both groups, of stressed men compared to the reference values. The number of healthy sperm was significantly higher in the treated group than the therapy, after the therapy, indicating a recovery of the sperm quality. The effects induced by stress also seem to, include meiotic and structural alterations in the sperm cells. The main alterations in the sperm pathologies were related to apoptosis and necrosis, marginated chromatin and swollen and badly assembled mitochondria were the typical ultrastructural markers of apoptosis, as we all know. And the reacted or absent acrosomes nucleus with disrupted chromatin and broken plasma membrane were signs of necrosis. So this is how we find out necrosis and apoptosis. Sorry, I just have some water. Relationship between psychological stress and reproductive outcome in women undergoing in vitro fertilization treatment, psychological and neurohormonal assessment. So this is another article published in the Journal of Assisted Reproductive Genetics. So the purpose of this study was to evaluate whether psychological stress as well as the changes in the HPA axis and sympathetic nervous system at different time points during a first IVF cycle correlates with the reproductive outcome or not. So what did we find in this? Anxiety is associated with both pregnancy rate and live birth rate. In the IVF patients, an effect is partially mediated by activities in the HPA and SNS. So norepinephrine levels during the study, as we can see here, it is much higher in pregnancy than in non-pregnant state. Much lower in pregnancy than the non-pregnant state. And the cortisol levels in this study, as we can see, it is much lower again in the pregnant state than the non-pregnant state. So the state of the anxiety is definitely associated, and the pregnancy rate and live birth rate in IVF too. So another research article that we can see here, that is, as it is the era of evidence-based medicines, we need to quote our articles in our studies to prove that what we are saying, the points that we are telling are definitely have been proved by many studies on real people. The effect of the psychological distress on IVF outcomes, is it a reality or is it just a speculation? The rates of the stress, anxiety, and depression among IVF patients are higher than in the general population. If the level of the infertility-related stress is higher, IVF success rate is lower. So the findings of our study indicate the need of the specific psychological interventions for all infertile women to improve the IVF success rate. So we can see it is negatively proportional and negatively associated with the outcome of the IVF. So this is how we are going to go about it, and it is not about the commission, it's also about the omission. We should not neglect and we should not omit that aspect of infertility. The prevalence of depression symptoms among infertile women, a systematic review and meta-analysis. The prevalence of depression among infertile women was higher than that among the general population of a given country. Especially in low and middle income countries, appropriate measures, planning, and policy that target the negative effects of depression on infertile women's life should be established to reduce related problems. So this is what the conclusion was from another article in the Fertility Research and Practice published. So coming to another article published in the Psychotherapy and Psychosomatics Journal, stress management during the intracytoplasmic sperm injection cycle may slow down first embryo cleavage and accelerate the embryo compaction, a pilot randomized control trial, of course. The herein reported SMP seems to be efficient in reducing the stress levels among couples undergoing ICSI cycles. Interestingly, it may also influence the granulosa cell physiology and embryo development, kinetics in participants with a good prognosis. Impact of stress on fertility. So it responds to the stress of being unable to conceive, and by aggressively pursuing the treatment and procedures, patients withdraw and isolate from family, friends, and community. Most people who cannot get pregnant have an actual physical explanation, but as month after month goes by, feelings of stress, anxiety, depression often kick in, and most of the time they do kick in. Even if the physical cause of infertility is treated medically, surgery for endometriosis, problems with low sperm count and others, it's possible that high levels of stress can still make getting pregnant more difficult. So it is definitely required to lower it down. Infertility causes stress which is aggravated as time passes and the couple remains infertile. Couples participating in an IVF program are highly stressed, especially after a failed IVF cycle. The clinical relevance of the second factor. Sorry, I just missed a slide. Yeah. Stress because of IVF procedures, taking time off from the work for doctor appointments, having the blood drawn, having pelvic examinations, ultrasounds, injections, timing of the intercourse, various diagnostic procedures, and cost factor, definitely one big thing. So these are the various apprehensions and various, blocks, roadblocks that they have to go through. Efficacy of the reduction of stress before fertility treatment commences, that there are evidence that personality dimensions, coping modes, stress susceptibility, and resilience correlate with IVF outcome. Recent studies indicate that the stress increase the dropout rates from the treatment. So this is another important aspect, that people discontinuing the treatment because of this particular reason. Psychological interventions such as behavioral treatment aimed at reducing stress in IVF have shown to be effective in several studies. A recent meta-analysis showed that psychotherapy accompanying IVF is also effective. Short-term goals for male and female fertility patients. Short-term goals for male and female fertility patients, there is reduction of feeling of helplessness through coping with infertility, changes in sexual behavior, modification of, negative cognitions as to infertility, overcoming deficiency in knowledge about fertility, improving the marital communication skills. So these are the various short-term goals that we can provide to our patients, and we can also be a kind of a counselor and tell her or him how to go about it. Two main factors which appear in the chronic stress that determine what influences the psychological condition and mood state in a couple on the fertility treatment. The first factor is the way in which the person handles the stressors in general. We need to really know what is going and what is happening. If that coping way is less than adequate, stress may become chronic, and chronic stress affects fertility. That's very important, that we first recognize that the couple is under stress. The second factor refers to how the person handles the threat to her or his self-esteem, or her or his biological and social value, which results from the knowledge that something is amiss with her and or his fertility. As a result, anxiety and altered mood states in general are common from the moment doubts as to a couple's fertility arise and increase sharply on account of the fertility treatment itself. So the clinical relevance of the second factor is well established and is up to now the one factor that fertility treatment sometimes take into account and will try to control with psychological approaches. However, more and earlier attention should be paid to the first factor, as chronic stress is an important influence on the treatment outcome. So we need to recognize it, then deal with it, and find out various ways to know how to go about it. Religious and social beliefs should be, could be considered markers for fertility related stress in their own right. As I said, in our Indian society, it is more so, but even in the Western world. So there are various factors. So social stigma, religious stigma, and so many other things which are very, very important. And we need to know what the couple is going through, so that in the treatment is being followed in the particular proper way or not, or they're getting deviated because of various assumptions or apprehensions in their mind. Establishing stress levels before fertility treatment, a physician other than the fertility clinic specialist, often the gynecologist, usually makes a preliminary diagnosis of the infertility. This physician should also establish the stress levels with the help of validated questionnaires, or simply asking leading questions, or to refer to a psychologist for purpose if they, if you suspect something is wrong, that chronic stress is playing role. His findings will not yet be affected by the additional stress produced by visits to a fertility clinic. If indicated, stress reduction techniques should be applied, and after 3 months, stress levels should again be measured with same questionnaires. The couple is then referred to the fertility clinic. The fertility clinic again establishes stress levels, this time both psychological and biological, and compares findings with the previous uncontaminated measurements to determine the susceptibility to stress treatment. If levels are still over-established, individuals' thresholds, another 3 months of stress reduction is attempted. So we have to first try before starting the fertility treatment. When stress reduction is obtained, fertility treatment is initiated with concurrent stress management for both. If they remain over-established thresholds, the couple should be advised on increased probability of a negative result of the fertility treatment, and should be recommended to continue with therapy until lower stress levels are attained. However, if they insist, an informed consent should be signed. Establishing stress levels. Sorry, 1 second. Yeah, establishing stress levels before fertility treatment. First is diagnosis of infertility. Establish male and female chronic and acute stress levels with validated questionnaires or simple leading questions. If over thresholds, intensive stress reduction techniques for 3 months at least. Establish stress levels and refer to a fertility clinic. Establish male and female chronic and acute stress levels with psychological and biological assays. If over thresholds, intensive stress reduction through psychological and adjuvant dietary treatments for 3 months. When and if reduction is obtained, initiation of the fertility treatment with concurrent male and female stress, management. So this is a basic flow chart and something that we are going to adopt in our clinics as clinicians also, how to go about it. Several studies present promising results of psychological interventions leading to higher pregnancy rates. State anxiety has considerable validity as an independent marker for better pregnancy rates on account of the effect of anxiety on the implantation period of the fertility cycle. To improve overall pregnancy rates is not simply a matter of reducing the acute stress, but rather of finding ways to improve efficiency of the adaptive response to stresses. So we're just telling that just reduce stress is not going to work. We need to find out what are the stresses first. Then we need to find out a way how the person is going to accept it and then adapt how to go about these stresses, because they're going to keep on coming every now and then with every procedure and every advancement, and also in every failed result of it. So here we have the interventions for stress control and the fertility treatment, protocols to include patient selection according to existing chronic stress levels in response to acute stresses, preliminary treatment to reduce anxiety and depression before fertilization cycles are initiated. Psychological means are cognitive behavioral therapy, relaxation training, differential orientation as to infertility, fertility sabbatical permit. That's very, very important. You need to take a break for everything. Technically means frozen backup semen samples taken at low stress moments outside the fertilization cycle. That's also a wonderful time management that we can see here. Whenever the person is a little free and less stressed, and we can definitely cash on and use that period of time both for the male and the female. Further refinement of the fertilization techniques such as removal of the acrosome before ICSI. Now, as told by Morozumi and Yaganimachi in 2005, neurobiological means establishing individual baselines and specific stress markers, establishing thresholds for referring, monitoring for stress before and during fertility treatment. Ethical and technical reasons for stress management before fertility treatments. Presently available evidence support the following 3 assertions. Infertility causes stress in the couple involved. Infertility treatments cause stress in the couple involved. Stress may be a primary or a secondary cause of infertility. For each, the level of evidence is different. The first two having been repeatedly confirmed by acceptable studies, as we mentioned, so many studies, and we can see here how each and every factor is responsible, and each and every procedure of infertility can affect it. And whereas the third is supported by a number of studies that are acceptable in design and execution, should be taken as probable yet not conclusive evidence. Coming here, stress management. No one expects patients to approach fertility treatment stress-free. Finding ways to minimize stress while pursuing treatment can help. So we know that it's not very easy. Saying it is too easy, doing it is very difficult. So we need to find out various approaches, as we mentioned earlier, technical approach or a neurobiological approach or a cognitive behavioral therapy approach or whatever. Ways to reduce stress. We need to talk to the partner, we need to tell this. Remember, you're not alone. Talk to people with infertility through individual or couple counseling or support groups. Read the books on infertility, which will help you to be normal and can help you deal with stress. Stress reduction techniques such as meditation, yoga, progressive muscle relaxation, or acupuncture Avoid taking too much caffeine or other stimulants. That's another important thing, because most of the younger generation and the reproductive age group people are definitely addicted to caffeine and other stimulants. Exercising regularly to release physical and emotional tension and the release of endorphins in the body. So the supplements that can reduce the level of the serum stress hormones, cortisol and adrenaline, can boost the fertility and increase the chances of becoming pregnant. So we need to find out a way also to reduce the serum cortisol and reduce the serum adrenaline. This is a wonderful drug that has been launched by Shield for the stress and anxiety and infertility. The oral spa that you call it, it's Lactium 150 mg with L-theanine 100 mg. It relieves stress and anxiety, normalizes the cortisol level, improves the reproductive function, improves fertility outcome. As I said, as we have already spoken about how the HPO, HPA, and the HPG axis, how they stress affects each and every axis, and how the release of the glucocorticoids, the excessive release of the cortisol and others, they have this negative feedback and in short lead to various stages of the oocyte maturation. So we need to be calm to conceive and improve the fertility outcome, and I think Ora Spa is going to help in it. So what does Lactium do? It is a milk protein hydrosilate which contains a bioactive decapeptide with anxiolytic properties, also called alpha casozepine, is produced from the milk protein casein. Lactium was developed after 12 years of research in the Ingredient Laboratories, France. It works effectively and naturally in stress and anxiety. It causes no side effects, neither addiction nor sedation. So it's a wonderful milk protein. So it acts on the hypothalamus, again stopping the release of CRH, stopping the release of ACTH, which acts on the adrenal gland, and thus leading to decrease in cortisol and decrease in adrenaline. So 25% reduction in stress-induced cortisol levels within 3 hours. So it's a wonderful thing. So reduction of stress-induced cortisol levels regulates the GnRH pulsatility, normalizes LH and FSH ratio. So for females, it normalizes estrogen production, improves the oocyte quality, normalizes the progesterone function. In males, it normalizes the testosterone production, normalizes the spermatogenesis process. Lactium, it selectively binds to this to GABA receptors, improves GABA activity, no binding to omega-1 GABA receptor, no sedation. So this is how it acts, and because there is a selective binding to it, so we do not have sedation involved. Coming to the L-theanine part, it's a natural constituent in tea, and its effect on the mental state can be seen in this article. There's an evidence from the human EEG studies show that it has a direct effect on the brain. L-theanine significantly increases activity in the alpha frequency band, which indicates that it relaxes the mind without, inducing drowsiness. So it's a wonderful drug again. The benefits in stress, we've already said, regulates the hormonal pathway, reducing stress-induced cortisol and adrenaline, regulates the neuronal pathway, increased GABA and decreased glutamate activity, improves the coping mechanism, improvement in alpha waves that leads to good quality sleep, and improves the fertility outcome. How does it improve again? As we have already mentioned here, regulates GnRH and gonadotropins, regulates estrogen and testosterone, regulates oogenesis and spermatogenesis, regulates the progesterone, improved endometrial receptivity, regulates libido. So each and every level of, the process is affected, and this is how it improves the fertility outcome. So no sedation, no zero tolerance, no addiction, and no withdrawal symptoms. So the take-home message here, what do we get from such an extensive and expansive discussion that we had? We know that infertility can cause stress that leads to anxiety and depression. Stress can make conception more difficult for men and women. Stress reduction techniques, when employed on a regular basis, can improve conception rates. Stress reduction is a non-invasive, less expensive, and ethically acceptable way of improving infertility. Fertility treatment protocol should include stress management and stress reduction as factors of major importance. The professional in reproductive medicine should always test for the chronic stress before initiating the fertility treatment and adjust selection and treatment protocol accordingly. So before going and regulating the pathways through other mechanisms, I think we can also simply, try to reduce stress either through our wonder drug, that is Aura Spa, or through various other therapies and cognitive, and just merely counseling and talking to them and reassuring them, it's going to do wonders, I feel. So thanks a lot for this opportunity and the platform on Shield to speak on this wonderful topic. I'm really grateful. Thank you.
Thank you very much, madam, for this nice and presentation. And just give me 2 minutes time to check the questions. And meanwhile, if you permit us, then I can share this information on this stress and infertility pathway.
Yeah. Is my face visible now? There was some message.
Yes, ma'am. Yeah. It is visible now.
Yeah.
So, ma'am, I'm sharing one short video.
Yeah.
In today's world, stress and anxiety caused by many day-to-day factors lead to infertility both in men and women. Chronic stress and anxiety have negative impact on 3 pathways.
In hormonal pathway, stress leads to the increased production of cortisol and adrenaline, leading to reduced insulin secretion and increased glucagon production. This triggers glycogenolysis and aggravates hyperglycemia. In men, high cortisol and adrenaline induces Leydig cell apoptosis, decreases testosterone level, and affects spermatogenesis and leads to loss of libido.
In women, it leads to irregular menstrual cycle, induction of granulosa cell apoptosis, affecting estradiol production and oocyte quality, decreasing libido.
Ultimately, the fertility outcome is affected.
In neuronal pathway, there is reduced GABA activity and increased glutamate activity. This leads to failure of stress coping mechanism. Reduced GABA activity leads to inhibition of GnRH and impacts fertility outcome.
In the brain, stress induces the high beta waves, causing anxiety.
High stress impacts different stages like IVF preparation, oocyte retrieval, embryo transfer, and pregnancy test, leading to reduced IVF success rate. Doctor, in essence, an ideal stress solution should work effectively in all the 3 pathways, be better and safer than benzodiazepines.
Have you ever wondered why after breastfeeding infants feel relaxed, calm, and sleep? It is not because of satiety. It is in fact on account of alpha-casozepine, Lactium, God's natural gift to infants, the natural stress solution. Alpha-casozepine is the original research of Ingredia, France, in collaboration with University of Nancy. In infants with partially developed digestive system, casein is converted to alpha-casozepine by trypsin. Alpha-casozepine calms the mind and makes the infant sleep.
Introducing God's gift to couple. Aura Spa, the oral spa, a calm way to conceive.
Each capsule of Aura Spa contains alpha-casozepine as Lactium 150 mg and L-theanine 100 mg. Aura Spa, the ideal and natural stress solution, acts on all 3 stress pathways: hormonal, neuronal, and brain waves.
In hormonal pathway, Aura Spa reduces stress-induced cortisol level in 3 hours. Hence, the GnRH is activated In female, it prevents granulosa cell apoptosis, normalizes estradiol production, and improves oocyte quality. In male, it prevents Leydig cell apoptosis, normalizes testosterone level, and improves spermatogenesis. Thus, Aura Spa improves the fertility outcome.
In neuronal pathway, it increases coping mechanism and GABA while decreasing glutamate activity. Stress levels are significantly reduced and sleep quality improved.
In the brain, L-theanine produces alpha waves and relieves stress and anxiety in 40 minutes. Aura Spa is approved with US FDA GRAS, Korea Food and Drug Administration, AFSSA. Dose: 1 capsule once a day for both the partners.
Aura Spa, God's gift to infants, is now available for couple. Calm to conceive and improve fertility outcome.
Thank you very much, ma'am, for permitting us to share this nice video. So, ma'am, yes. So, ma'am, one question is in your day-to-day practical practice. So, how will you manage this stress condition, and what will be their approach for counseling these patients who are suffering from these infertility issues?
No, as I said, we first need to recognize that the couple is under stress before going about anything. So I think that is the most important thing. Once we come to know that the couple is actually under stress, so we can definitely talk to the couple, try to find out what are the stress factors, what is the issue behind it, whether it's a religious or social stigma, or it's simply some job issue or something. And if we can advise them, or when we find that it is quite difficult for them to open up or to have a thing, we can definitely suggest a psychologist or a therapist. And we can also go about with drugs and other things. So we need to find a comprehensive approach. First, we need to diagnose the problem, and then counsel the couple that this is a very, very big factor involved in their treatment.
Thank you very much, madam. And ma'am, one question is, what is your opinion on these benzodiazepines in case of these problems?
See, when it is too much, I think we can definitely think of it as an option. I'm not saying that we are going to rule it out completely as an option, but we are going to keep it towards the end. We are going to try all kinds of therapy before switching over to benzodiazepines. So I think we can try our therapies, our different approach, our counseling, our Aura Spa drug, and then we can think of benzodiazepine if it's too much and too severe.
Thank you very much, madam.
Yeah.
And one question is, ma'am, only this counseling will give you a practical scenario whether this particular patient is suffering from any other anxiety or stress conditions, or is there any other test to determine this stress condition?
No, that is also there, and then we can also have an idea from various things. We can know from the weight of the patient, the BMI, if there is any eating disorder. We can definitely find it out when the patient is anorexic or bulimic, overweight, and we can find out from that. Or we can also assess it from various. We can get a blood test and rule out any insulin resistance and other things. So there are various things in which, as I said, it's a comprehensive approach. We can just by counseling and talking to them, we can, but then we can also see how the patient is going through each and every step of it. How is the compliance of the drugs and other things, and also how the couple is together going forward for it, or definitely there is an effect on it. So besides counseling, we can also clinically assess the patient in many ways with history and the normal the body mass index and investigations can also give us reflect on the issue of stress.
So thank you very much, ma'am. I could not find any other question. So thank you once again for your valuable time on our platform to discuss such as this emerging topic, which is very hot topic, as you told already.
Yeah.
That's stress and infertility, and we are also trying to address this issue with our newly launched OASPA. So thank you once again for your valuable time, and in future also we will be looking forward for some valuable session with you. So thank you very much.
So